Mm. Good evening, everyone. So we'll be continuing our lectures this week with the Palmoplantar Keratodermas. Now I understand that it is a part of a chapter which is, in my belief, it's my personal opinion, that the chapter is a very dry chapter. It becomes difficult to make sense of what is happening. And we started few weeks ago when we were discussing the ichthyosiform disorders. And to make sense of what is happening, it's better to divide them into separate parts. And to make a difficult concept easy to understand, it is essential that we take one piece at a time or one portion at a time, and then we go through it at our own pace and make our own notes and try to understand what exactly is happening. So, with that in mind, I've decided to separate Palmoplantar keratodermas into non-syndromic and syndromic type so that it becomes easier to understand. So this week we'll be continuing our lecture series, and the first part is non-syndromic PPKs. Okay, so Palmoplantar keratoderma, non-syndromic one. So without much further ado, let's start a discussion on Palmoplantar keratodermas. And I'm sure that if you go through this lecture video, a lot of you would be able to find it quite easy to grasp what are Palmoplantar keratodermas. Okay, so let's start our discussion. Now, palmoplantar keratodermas are heterogeneous group. That means it's a collection of different type of diseases presenting with a common symptom of palmoplantar keratoderma. Now, what is palmoplantar keratoderma? It is excessive epidermal palmoplantar thickening. So it is thickening of the palms and soles. That is what it is. Other areas that can be involved are mucous membrane, sweat glands, nails, and hair. So you need to examine these structures also. So right now we're discussing non-syndromic, but when we will discuss syndromic PPKs, we will understand that involvement of other organ systems and other keratinaceous structures are important to classify as different syndromes. Okay, so we need to examine all of these features. Now, so I've decided to divide it into non-syndromic, syndromic, and acquired PPK. And this week we'll be discussing the non-syndromic palmoplantar keratoderma. So let's move forward. Now, before we start a discussion on PPKs, there are some points or some definitions or some words that we need to familiarize ourselves with. Okay, the first one is punctate. Punctate means like a puncture wound, point-like. It is also known as papular or disseminated type, in which the keratodermas or the keratin material, or you could say the thickening is dot-like, pinpoint, and papular. Okay, so it's like a dot. Focal keratodermas, also known as areate or nummular. Nummular means disc shape, like nummular eczema. Here, there are small areas, especially over pressure points, which are thickened. Striate. Striate means like a stria or a single layer okay, or longitudinal, and that is especially over the flexor tendons. So over the fingers where the fingers flex. So over the flexor tendons, you have a linear thickening. Diffuse. Here, the large areas in palms and soles are affected. So the whole palm would be affected, a large area, and can have complete keratoderma. That means the entire palm is thickened. Confluent means around the digit, so it will encircle. So if this is the finger, so it will, and the thickening will be all around the digit. So that is known as confluent PPK. Transgradients. Transgradients is when the thickening is over the ventrum and the dorsum of the hand. So it extends on both the surfaces, front and back. Now, progradients. Progradients, I have found two different definitions. The important one is that it worsens with age. That means the keratoderma, the thickening, increases with the age of the patient. Another definition that I have found is that it extends over the wrist and ankles. That means after involving the palms, it will extend and cross the wrist, or after involving the soles, it will extend and cross the ankles, going towards the Achilles tendon and shins. So that is also progradients. But if an exam somebody asks you what's the meaning of progradients, first thing to reply should be that's a progressive worsening of keratoderma with age. Let's move forward. Now, in order to understand non-syndromic PPKs better, it is imperative or it is important to differentiate three different morphologies. One is diffuse, that means the entire palms, focal, localized areas, or punctate, pinpoint. Clear? So in diffuse PPKs, you have disorders like epidermolytic PPK, Unathost, Bothnia, Nagashima, Mal-De-Meleda, Griffiths, and Loricrin Keratodermas. Okay, these are examples of diffuse keratodermas. In focal keratoderma, when you have localized lesions, you have the striate keratoderma, Watcher's keratoderma, which is a variant of striate keratoderma, and Pachyonychia congenita. Clear? In the punctate one, where you have pinpoint, you have the Palmoplantar Keratoderma punctata or type 1. Then you have the spinous or type 2, or you have the marginal or type 3. Additional fourth disorder that shows punctate keratoderma is cold disease. And in this lecture, we will discuss all of them in detail. So let's move ahead. So we'll start our discussion now with individual non-syndromic PPKs. Starting with the first PPK, epidermolytic PPK. It's the most common diffuse palmoplantar keratoderma. So this is a good point to remember. It's the most common diffuse palmoplantar keratoderma. Now, in epidermolytic PPK, the other names for that you have to remember is Werner Unathost keratoderma, VUT. Okay, also known as Werner's disease or Unathost disease, but let's not confuse ourselves with the non-epidermolytic one. The epidermolytic PPK is known as Werner Unathost keratoderma. Okay, the mutation lies in keratin 9, and keratin 9 is expressed only in the palmoplantar skin or majorly in the palmoplantar skin. So I would suggest you that you go back and see our lecture on keratinization to understand that in every different type of tissues, you have different type of keratin expression. Since keratin 9 is majorly seen over palms and soles, when keratin 9 is mutated, you have epidermolytic palmoplantar keratoderma. Some mutations were also found in keratin 1, but the major mutation is seen in keratin 9. Okay, let's move forward. So on biopsy, you will see epidermolysis, okay, or separation in between the layers of the epidermis. And mostly this separation occurs at the suprabasal level, and you can have eosinophilic inclusions inside the separations. So in epidermolytic PPK, on biopsy, you will see epidermolysis, that is the name. Now you have what are known as tonofilaments. So what it actually happens is, we know that you have a nucleus, we know that we have a cell, and keratin filaments, they tend to be part of cytoskeleton, okay, normally, and they attach nuclear membrane to the cell membrane, and that is how a cell maintains its shape. Okay, if the keratin are not properly formed or mutated, for example in the disorder of epidermolytic PPK, this keratin will not form strands, they will not form wires, they will get clumped together. Okay, and these clumps are known as tonofilament clumps, and this is what you see in a biopsy. Clear? And because of the wires not being there, or there are improper keratin, the cell is not able to maintain its shape and gets damaged easily. And this damage leads to epidermolysis, and this epidermolysis leads to epidermolytic palmoplantar keratoderma. Clear? Now, there can be disabling pain in a variant which is known as tonotubular EPPK, in which there is keratin 1 mutation. That means if you have mutations in keratin 1 gene, the chances of having palmar pain or sole pain is significantly there. Okay, and on biopsy you will see whorls of keratin. So these are the whorls. This clump keratin is whorls of keratin, and they have these tubular structures. These are known as tonotubules or tonofilaments. Clear? Let's move forward. So the clinical pictures are on these pages of Rooks 10th edition, Fitzpatrick 9th and Bolognia 5th edition, and I'll be discussing clinical features of epidermolytic PPK. We know that it is the most common diffuse keratoderma, and after that it becomes more confluent. That means it first involves the palmar surface, and then the entire hand might be involved as the patient goes to adulthood. You may not see blistering or epidermolysis when the patient presents to you, but there is always history of blistering in the past. Hair, teeth, and nails are normal. In fact, in some mutations of keratin 9, some nail changes are seen, but mostly these structures are normal. Okay. There's another disorder by the name of Greither Keratoderma, but we'll discuss that later. Treatment includes mechanical debridement, that means either you cut it out or you rub it with derma abrasion to remove the excess keratin. Mild keratolytic relubrication using urea and lactic acid or salicylic acid creams, and topical calcipotriol and oral retinoids have been tried with moderate benefit. So here we can see epidermolytic PPK, and this is the pictures that I've taken from the respective references here. And you can see that there is diffuse involvement. The entire sole is involved, or the entire palm is involved. Okay, so there's diffuse involvement of palms and soles, and you can have a little, you can have this red border, this erythematous border, because epidermolysis is happening. The epidermis is splitting. So you can clearly see this red border at the margin of the ventrum and the dorsum surfaces, uh, at least before it has involved both the surfaces. Okay, so this is the feature of epidermolytic PPKs. Now, the second disorder, okay, the second disorder of the non-syndromic PPKs is Pachyonychia Congenita. It's an autosomal dominant disorder, and the mutation lies in keratin 6A, 6B, 6C, 16, and 17. Okay. Earlier, it was classified as type 1 and type 2. PC type 1 was known as Jadason-Lewandowski syndrome. It had PPK with oral leukokeratosis, okay, oral white plaque in the oral mucosa. The type 2, also known as Jackson-Lawler type, had more of pilosebaceous cyst and neonatal teeth. Neonatal teeth means the baby is born with teeth inside, teeth in the mouth. Okay, but this was an older classification. Now we know that actually what has happened is the recent classification. The individual gene defect is taken as a point of classification. That means we don't now we don't group PC into type 1 and type 2. We see PC with 6A mutation, PC with 6C mutation, PC with 17 mutation. Okay, because we know that each and every genetic mutation has their own clinical features. So we don't have type 1 or type 2 now. We have 5 types of PC depending on what gene is mutated. Clear? So now we have 5 types of Pachyonychia Congenita. Let's move forward. Now the clinical features is most commonly you will see 3 main features in Pachyonychia Congenita. You will have toenail dystrophy. You can also have fingernail, but toenails are mostly affected. Toenail dystrophy with plantar keratoderma and plantar pain. Okay, and plantar pain is a significant feature which you see in Pachyonychia Congenita. So you have thickened toenails, that is because of nail bed hyperkeratosis. You see it within 9 years of life. You have plantar keratoderma with calluses, fissures, thickened skin, and thick yellow keratosis over the pressure points. So much so that friction blisters can also happen. The plantar pain is significant. It significantly impacts quality of life. You require painkillers and wheelchairs for movement. Other features are follicular hyperkeratosis, oral leukokeratosis, I've told you before, palmoplantar hyperhidrosis, cyst, and natal teeth. Now remember, whenever keratin is affected, you will have problems in sweat glands also. And that is why most of the disorders of non-syndromic PPKs have hyperhidrosis as a feature. In oral mucosa, you see patchy white thickened tongue in oral mucosa. So you see a white plaque in the oral mucosa. Laryngeal involvement in the form of hoarseness or fatal respiratory obstruction is also reported. Here again, we see nail dystrophy, we see thickening of nails, and we see this kind of friction blisters happening. So this is showing friction blisters. And here you can see the white plaque over the oral mucosa. So if oral mucosa is involved, we can say that it is mutation in the 6A keratin. In the axillary portion, you can see cyst, that means the mutation in 17 keratin, and you have the focal PPK. We are clear about now Pachyonychia Congenita. Let's move forward. So this is a picture which I myself clicked in my, I think the first or the second month of my junior residency. And this is a picture of Pachyonychia Congenita. You can see this thickened, extremely thickened, deforming nails of the fingers. And look at how it has formed a hump. It's because of nail bed hyperkeratosis in this type of Pachyonychia Congenita. And you can see the nail plate is somewhat normal. not normal per se, it is hyperpigmented, it is slightly rough. But look at the significant nail bed hyperkeratosis that you see. Okay, significant nail bed hyperkeratosis. And that is a feature of Pachyonychia congenita. Let's move forward. Now, on biopsy, we see tonofilament aggregates. Why? Because the mutation lies in keratin. So always remember, whenever there is a keratin mutation, you will see these kind of tonofilaments. And this is in fact true for epidermolysis bullosa also, or wherever the keratins are mutated. In different type of ichthyosis, you will see tonofilaments only when the keratin gene is mutated. Okay, so keratinopathic ichthyosis will show tonofilaments on electron microbiopsy, electron biopsies or biopsies. Now, biopsy on histopathology, you have gross hyperkeratosis, thickening, with alternating orthokeratosis and parakeratosis, with acanthosis, again thickening, hypergranulosis. Why? Because the keratin, the cell has to make a lot of keratin because keratin is not working properly. So many granules are formed. But there is no gross epidermolysis. That differentiates it from epidermolytic PPK. Clear? You do mutation analysis so that individual gene, individual keratin which is mutated can be seen. Treatments include emollients, keratolytics, mechanical reduction with filing, cutting, grinding, soaking, dermabraiding the thick nails, proper footwear and orthotics so that the pain is limited and the patient can walk properly. If there are cysts, then it has to be surgically removed with or incision drainage can be tried to help it. Okay, so cyst you have to remove, and orthotic treatment and mechanical debridement of the thickened nails. Clear? Let's move forward. Now, the third entity that we discuss is non-epidermolytic PPK. So first we discuss epidermolytic PPK. Now third we'll be discussing non-epidermolytic PPK. In this you have diffuse keratoderma, but there is no cytolysis in the upper spinous or granular layer. That means there is no epidermolysis, as the name suggests. No epidermolysis. This is known as Thorst-Unna keratoderma. Don't confuse it with Unna-Thost disease, that is epidermolytic PPK. This is Thorst-Unna keratoderma. Now, three types have been identified, and in fact, many authors would like to keep these types as a separate keratoderma, but I've grouped them together in non-epidermolytic PPK. You have the Bothnia type, the Kimonis type, and the Nagashima type. Okay, in Bothnia, you have problem with the aquaporin 5 gene. And because of aquaporin, now aquaporins are channel that is responsible for water transmission in between the cells. If these are mutated, then the water is retained inside the cell. It's not able to move freely, and that leads to increased water retention. In Kimonis type, it is autosomal dominant transmitted, and the mutation is in keratin 1. In Nagashima type, it is autosomal recessive transmitted, and the mutation is in serpin B7. Clear? So we just remember this. These are good quiz questions or Viva or MCQ questions. Okay, let's move forward. The clinical features starts with few months of life to about 2 years. It is even, thick, yellow diffuse hyperkeratosis over soles first and then palms. So it develops first on soles, then the palms. It has a well-defined red border, but it's not because of epidermolysis. Okay. It is transgradients, that means it crosses the margin between the dorsum and the ventrum. There is hyperhidrosis, like we said, and there's increased chances of fungal infection. Why? Because fungus feeds on keratin, and in PPKs, you have a lot of keratins, and it is moist because of hyperhidrosis, because of water retention. So it becomes easier to infect. So you have increased fungal infections. Nails, hair, and teeth are normal, but you have to examine them. Investigations include genetic analysis, but biopsy rarely helps. There's no point. You may do biopsy to rule out other causes of PPK, but biopsy rarely helps in non-epidermolytic PPK. Management is by keratolytic therapy using 5 to 10% salicylic acid in paraffin or 5 to 6% salicylic acid in 70% PEG. Okay, so 5 to 10 in paraffin or 5 to 6 in PEG. Low dose systemic acitretin by the dose of 0.2 to 0.5 mg per kg is as found to be helpful. You treat overlying fungal and bacterial infections that is happening. Now, few studies mention the use of erythromycin in Bosnia type or topical tacrolimus in Nagashima type. So this has been mentioned and it's also mentioned in Rooks. So I mentioned it here. Let's move forward. The fourth entity now is Greither syndrome. Greither syndrome. This is known as transgradients A progradients PPK. A is a French word for and. Tinea corporis A cruris. Okay, so transgradients and progradients PPK. That means it crosses the margin and it progressively gets worsened with age. It's an autosomal dominant acquired disorder, starts from the second year of life, with diffuse, thickened, scaly yellowish keratoderma with an erythematous rim and transgradients. That means crossing the margin. It crosses the margin of the sole also to involve the Achilles tendon and progresses over the shins. So like we say, the first definition of progradients, that means increasing with age is also there, and it increases and crosses the margin of the soles over time. Greither syndrome tends to involute after fifth decade of life. Okay, that means after the age of 40s, the fifth decade starts, it involutes, it goes back and improves. There is hyperhidrosis and there's petit keratolysis. Rarely spontaneous autoamputation or delayed deformities can also occur. Let's move forward. The fifth entity is Mal-De-Meleda, and it's an important disorder. Okay, at least from the Viva point of view or from residency point of view, Mal-De-Meleda is a very important disorder. It is known as Keratoderma palmoplantaris transgradients. So the transgradient is in the name. Acroerythrokeratoderma or Meleda disease. Now, Meleda is a very small island in the Adriatic Sea, and Mal-De-Meleda means disease of Meleda. So it was first described in that island, so that is why the name is Mal-De-Meleda. It's a rare autosomal recessive transmitted disorder, and it has transgradient keratoderma found on the Croatian island of Meleda. Clear? The mutation is there in SLRP1. So SULRP1 gene is mutated. SLRP1 is responsible for alpha-7 acetylcholine receptor, and this receptor activation is important for proper functioning and adhesion in the upper layer of the epidermis and the acrosyringium, the sweat glands. And when this is mutated, the upper layer starts to become more hyperkeratotic because the proper functioning and cell division is not controlled. The things that you have to remember is it's an autosomal recessive disorder. And we know that all recessive disorders are bad, they are severe. So Mal-De-Meleda is an example of mutilating PPK. Okay, other disorders are there like Olmsted, but we'll discuss them when we'll get to them. So it's a Mal-De-Meleda is an example of mutilating PPK. And the mutation is in SLRP1. So you have autosomal recessive, mutilating, transgradient, mutation in SLRP1. Just remember this. Clear? Let's move forward. The clinical features include onset in early childhood. Initially starts with erythema, but with age it leads to more hyperkeratosis. There's diffuse waxy ivory yellow hyperkeratosis in a glove and stocking distribution. So it's an example of diffuse PPK. We are discussing only diffuse PPK now. So it's a glove and stocking distribution. And I would like any one of you to comment wherever you have heard glove and stocking in dermatology. So just let me know in the comments. Insular lesions of the knees and elbows are a key feature, and this is important. What do we mean by insular? Insular means island. So what exactly is that you have a leg, okay? You have a leg, and this is the, let's say, the knee, and you will have well demarcated keratotic plaques over the knees. And that is known as insular involvement of the knees, and it's a key feature of Mal-De-Meleda. Hyperhidrotic maceration is there, malodor, fungal superinfection. You can have pseudo-anom formation, that is circumferential hyperkeratosis. That means if you, let's say this is a finger, and you have hyperkeratosis here, and this leads to constriction bands, and this is pseudo-anom. Okay, that is why Mal-De-Meleda is mutilating. You can have deformities of the finger, so it's a mutilating disorder. Nail shows hypercurvature, thickening, koilonychia. Koilonychia means boat-shaped nails, so the nails are curved like this over the finger. Okay. Rare features are angular cheilitis, melanomas, Bowen's disease have been described. This picture I've taken from Rooks. So again, from Fitzpatrick. So again, it's a diffuse Palmoplantar Keratoderma. Look at this diffuse nature. Okay, look at this red margin here. And if you look at this dystrophic nails, so nail thickening or dystrophic nails are there. Dystrophic nails. And here you can see the pseudo-inhum. Pseudo-inhum formation over the fingers. So it is constricting. You can actually appreciate the constriction. And these are the insular involvement, or the localized involvement over the knees and elbows, which are characteristic of Mal-De-Meleda. Clear? Clear about it? Let's move forward. The management includes oral retinoid, excision of the keratosis and split thickness grafting. That means you remove the keratotic skin and put a split thickness graft. Treat fungal and other superinfection and screen for secondary malignancies because melanoma and Bowen's disease have been described. So we have to screen them. Let's move forward. The sixth entity that we'll discuss now is Loricrin Keratoderma. Loricrin Keratoderma. It is also known as variant Vohwinkel syndrome. Now remember, Vohwinkel syndrome is different. Vohwinkel syndrome we'll discuss when we'll be discussing syndromic PPKs, but Loricrin Keratoderma is known as a variant Vohwinkel syndrome. So these two syndromes are separate. So use the word Loricrin Keratoderma while discussing. Also known as mutilating keratoderma with ichthyosis or Camisa syndrome. You have diffuse keratoderma. We are discussing diffuse keratodermas. Transgradient honeycomb keratoderma. So here's a picture of honeycomb. So in Loricrin keratoderma, the thickened plaque will have small craters in between, giving it a picture of honeycomb. So that is known as honeycomb keratoderma. So always remember the term honeycomb keratoderma is seen in Loricrin keratoderma. Okay, clear? And the ichthyosis is mild, it's not severe. I think I've discussed ichthyosis in the video on syndromic ichthyosis about Loricrin ichthyosis, but the ichthyosis in Loricrin keratoderma is milder. You have problems in the LOR gene mutation. That means the loricrin forming gene, and because of that, the loricrin is abnormal and it is dysregulated. And if you have gone through a video on keratinization, you will understand how important loricrin is for proper keratinization. And when that doesn't happen, you have keratodermas. Let's move forward. The clinical features include generalized desquamation at birth. Baby may or may not have a colloidal membrane, but remember the ichthyosis is mild. You have honeycomb keratoderma with diffuse edges in the childhood. Pseudo-inhum can be seen, and because of pseudo-inhum, Loricrin keratoderma is another example of mutilating keratoderma. So we have heard about Mal-De-Meleda and Loricrin. Clear? Let's move forward. So can you appreciate, look at this picture over the left hand side, can you appreciate that there is diffuse keratoderma? The entire palms are involved, even the fingers are involved, and this little craters, little bumpy keratoderma gives it appearance of a honeycomb. So that is known as honeycomb keratoderma. So here also diffuse involvement of the palms are involved with a honeycomb pattern of thickening. Okay, so let's move forward. The management in biopsy, you see hyperkeratosis, hypergranulosis, parakeratosis. In electron microscopy, you will see dense intranuclear granules in the granular cell because loricrins are accumulated. It's not functioning properly. Thin cornified envelope because loricrin is not there. Okay. In immune electron microscopy, you can actually see loricrin in nuclei. That means it is there in the nuclei. It's not there at the cell membrane. It has to reach the cell membrane to form the cornified envelope, but it's not going there because it is mutated. Now, it has been found that VEGF receptor is increases the abnormal loricrin. So inhibitor has been tried as a therapy, but not much benefit is there. Isotretinoin can be tried for Loricrin keratoderma. In fact, topical retinoids have also been used in some case reports with mild to moderate involvement. Mild to moderate improvement in Loricrin keratoderma. Mm. Now, the seventh entity is striate, also known as focal palmoplantar keratoderma. Now, with this striate group of disorder, or from striate onwards, we'll be discussing focal palmoplantar keratoderma. So, the first six disorders that we have discussed now of palmoplantar keratoderma are diffuse. Now, we'll discuss focal. That means localized. It's an autosomal dominant transmitted. Other names include striate PPK and other in one variant is Keratopalmoplantaris variants of Watchers. So that is one name you may know, but just remember that it is striate PPK. Now there are three types that have been described in striate PPK. The type 1 is desmoglein 1 mutation. Type 2 is desmoplakin mutation and type 3 is keratin 1 mutation. So depending on what gene is mutated, what protein is mutated, you have three different types of striate PPK. Let's move forward. So this table I've taken from Rooks. Okay, so this is the reference. This is the reference Rooks on this page, and we'll be discussing the three types of striate palmoplantar keratoderma. Okay. So just look at the mutation first. In the first one, you have desmoglein 1, the second has desmoplakin, while the third is keratin 1 mutation, especially the V1 domain. All the disorders are autosomal dominant in transmission, but you have a semi-dominant transmission in the type 1. Clear? The key features are that in striate palmoplantar keratoderma, remember in the initial part of the video, I told you that striate is a layer-like formation, okay? A single linear-like thickening over the fingers, and that is what is striate PPK. It's on fingers and palms. It is triggered by manual work and mechanical stress. That means more trauma leads to more thickening. In histology, if the desmoglein is mutated, you have problems in the adhesion of keratinocytes. And if you want to understand how desmogleins or desmoplakins play a role in cell adhesion, go through our video series on basement membrane zone and your concept would be clearer. Okay. So desmoglein 1 mutation leads to disadhesion of keratinocytes. The same thing happens when desmoplakin is mutated, and when you have keratin 1 as mutated. Remember, keratin 1 is a major keratin in the upper layers of the epidermis. So if that is mutated, you will see that the keratin intermediate filament network is improper. It's not properly formed. Okay. The gene mutation is also seen. Desmoglein 1 mutation is also seen in SAM syndrome, which is severe dermatitis, multiple allergies, and metabolic wasting. The same gene of desmoplakin is mutated in Cavajal-Huerta syndrome. We'll discuss this syndrome when we'll be discussing syndromic PPKs. And keratin 1 is mutated in a lot of disorders, one of them being ichthyosis Kurth-Macklin. Just remember and go through our syndromic ichthyosis lectures to understand what is Kurth-Macklin and what animal it is based on. Let's move forward. So here you can appreciate the linear arrangement of thickening. Look at this, like a line over the flexural tendons. Line over the flexural tendon. Okay, so you can see this linear arrangement of areas. In fact, over the soles, you can see that the pressure areas are more involved. The instep is somewhat spared. While in diffuse PPK, you have involvement of the insteps. You have involvement of the center part of the palms. But in focal, the center part is often spared. The instep is often spared. Okay, so you have linear arrangement of or linear thickening over the fingers, over the ventrum of fingers, over the flexural tendons. So that is striate PPK. Biopsy shows this adhesion of keratinocytes. We have discussed that in the chapter, in the table. If desmoplakin is mutated, so in electron microscopy, you will see abnormal keratin filaments around the nucleus. So again, remember that you have a nucleus, you have a cell, and then you have the keratin filaments attaching itself. The areas where the keratin filaments attach, desmoplakin plays an important role. So desmoplakin is here. If desmoplakin is mutated and not functioning properly, the keratin filaments will get crumpled together here. And that is what you see, abnormal keratin filaments around the nucleus. Okay. If desmoglein is mutated, desmoglein is an important part of the desmosomes. So you have reduced desmosome size. Treatment includes systemic acitretin or high percentage urea creams, roughly more than 40%, 40% or more, because that is when urea starts to become keratolytic instead of keratoplastic. The 10% that we normally use is keratoplastic. Let's move forward. The eighth entity is PPK punctata. So from 8th onwards, we'll be discussing punctate type of keratoderma or pinpoint keratodermas. It is known as type 1 Palmoplantar Keratoderma punctata. Type 1. So this is type 1. Okay. It's an autosomal dominant disorder in which you have small rounded papular lesions on palms and soles, and especially over the pressure points. Two chromosomes have been identified in which you have mutations. You have in chromosome 15, you have mutation in the AAGAB gene. And this gene is responsible for P34 protein. So when this gene is mutated, P34 is decreased. And when P34 is decreased, it is not able to control epidermal growth and keratinocyte proliferation. So the keratinocytes keep on growing without control and you have thickening and keratoderma. Clear? Another mutation is seen in chromosome 8 in the gene COL14A1 mutation, but that's a bit less. Mostly the mutation lies in chromosome 15. The other chromosome involved is chromosome 8 in punctata PPK type 1. Let's move forward. It's an autosomal dominant disorder, starts in early adolescence. So we have previously we have read or we have listened that it starts at birth or onset is early at birth, but this is a more late onset type PPK. It starts in adolescent. There are pinpoint keratotic papules, and they may have a depression in the center. So you will appreciate that when we'll go forward with the punctate PPKs, that most of the punctate PPK have a depression in the center. The severity can be variable and trauma increases lesions. That is why you have more on the pressure point. Dorsae of the hand and feet, knees and elbows are normal, no problems in that. Malignancies may be associated with the punctata type. Let's move forward. So here I've taken this picture from Fitzpatrick and you can see this, little pinpoint or papular lesions. They are not linear like striate. They are not larger than focal. They are little cones like morphology. Okay, cones or wart like morphology. So that are one of the important differentials of punctate PPK. So this is punctate PPK type 1. Let's move forward. On biopsy, you have autohyperkeratosis, compact acanthosis, hypergranulosis, and focal parakeratosis, like you always see in other biopsies of PPKs. Treatment includes orthotic footwear, and you can rub the keratotic area with a pumice stone. Keratolytic ointments, topical retinoids, topical calcipotriol were not found to be much beneficial. Systemic retinoids have mild benefit, but the major treatment lies in proper footwear and mechanical abrasion. Mechanical abrasion. We are clear on that? Now, tyrosine kinase receptor inhibitors have found to improve P34 signaling. So in PPK punctata type 1, you have problems in P34, you give tyrosine kinase receptors inhibitors and P34 signaling may improve and the keratoderma will improve. So it's a point where future therapies might be targeted at. Okay, let's move forward. Now, the ninth disorder is spiny keratoderma. Spiny keratoderma, also known as Palmoplantar Keratoderma punctata type 2. So initially it was type 1, now type 2. It is also known as music box spiny keratoderma. Now what's music box? So here is a cut section of music box. So in older movies, or if any of you know what a music box is, you crank a shaft, and then the drum this drum starts to roll. And when it rolls, it has these little points on it, these nubs. So cross section, you have this nub. And when this rolling drum strikes these metallic plates, it produces a sound. Okay, it produces one note. And when the whole drum rotated, multiple plates are targeted and you hear music. So that is known as music box. So, okay, so you in many of the older pictures you would have seen that a person rotates and then music starts playing. That is what is a music box. So it is in spiny keratoderma, you see this kind of spinous projections, and that is why it is known as music box spiny keratoderma. Now you understand? Now, it is also known as punctate porokeratotic, but that's a misnomer. It has nothing to do with porokeratosis. It's a rare autosomal dominant transmitted. It can also be idiopathic. It has fine 1 to 2 millimeter papules, which are filiform, spiked, prickly spines. That means this kind of spinous projections are present in the punctate one. So in the type 1 punctata, you have depressions or crateriform thickening of the papular areas. But in spiny keratoderma, they're sharper. Okay, they are more filiform, like hair. Starts in early childhood and is progressive. So it is another example of progradients PPK. So this picture I've taken from Bolognia, and if you look closely here, you can see that it is projecting outwards, just like you see the spinous projections over the music box. That is why it is known as music box spiny keratoderma. We are clear about it. Let's move forward. Biopsy shows dense columns of parakeratosis. You have a column of parakeratosis, you have a column of scale, you have a column of thickened keratin above a hypogranular epidermis. Clear? Treatment includes mechanical debridement. A tretinoin or acetretin therapy has found to have temporary benefit. Remember, acetretin has major action on hyperkeratosis. Okay, so as compared to isotretinoin, so acetretin is a better option to start in a hyperkeratotic disorders like PPK. You may have to screen with using an autoimmune screen or general baseline test or X-rays to look at different disorders that might be associated. Spiny keratoderma has some association with malignancies. Other diseases that are associated are polycystic kidney and liver, renal involvement, tuberculosis, hyperlipidemia, malignancies like multiple myeloma. In fact, spiny keratoderma can also be seen in type 6 PRP or the HIV-associated PRP. Okay, let's move forward. The tenth entity, also known as marginal papular keratoderma. It is also known as type 3 palmoplantar keratoderma punctata. So type 1 is punctata, type 2 is spinous, type 3 is marginal. Clear? Also known as acrokeratoelastoides or focal acral hyperkeratosis. But remember, these words have been grouped together. Okay, so marginal PPK or marginal papular keratoderma is a heterogeneous group in which some patients might show destruction of elastic fibers on biopsy, and then the disorder is known as acrokeratoelastoides. And some patients might not show any elastic damage, and then they are known as focal acral hyperkeratosis, but both have the same problem as marginal papular keratoderma. Okay. So in this marginal type, you have papules and plaques and nodules at the junction between the palmar and the dorsal skin. So if you look at your palms from the side, okay, you're looking at the side, this is the wrist, this is the palm, this is the finger, and I'll make a nail so that you're able to understand properly. We we appreciate that there is a margin going on, margin, and above the margin is the dorsum aspect, below is the ventrum aspect. In marginal papular keratoderma, you have lesions at the margins. Okay, you have lesions at the margin. That is why it is known as marginal papular keratoderma. Clear? Autosomal dominant inheritance is there, but it can be sporadic. Biopsy shows focal orthohyperkeratosis, and if it is in the form of acrokeratoelastoides, you will see elastosis or massive elastic damage or elastic fragmentation, elastic fiber fragmentation. If you don't see it, it can still be marginal papular keratoderma, but now it will be known as focal lateral hyperkeratosis. All words are same or the same disorder. Let's move forward. So this picture I've taken from Rooks, and you can see that this is the ventrum, this is the dorsum, and at the margin in between them you have this kind of crateriform depressions, and these are the marginal papular keratoderma. Clear? So you can go to the individual book page 63.60 and look at this photo. It's a very good photo. The 11th entity, and I know it's getting a lot. We have discussed about this is the 11th disorder we are discussing, but bear with me. And if you go through this video properly, slowly at your own pace, see it multiple times, it becomes so easy to remember non-syndromic PPKs. Now, in cold disease, it is known as guttate hypopigmentation or punctate PPK with ectopic calcification. Okay. Remember that from the PPK type 1, we are discussing punctate PPK. Okay. So, cold disease is another example of punctate or pinpoint keratoderma. You have congenital or early onset punctate keratoderma along with irregularly shaped hypopigmentation over the extremities. So white color macules or white color pigmentary disorders or decreased color pigmentary disorders is a feature of cold disease. So you can remember this as COLE. CO is cornification. That means you have issues in the uh, keratogenesis. You have keratoderma. And LE means light epidermis. That means you have decreased pigmentation in the epidermis. Biopsy shows defective melanosome transfer from melanocyte to keratinocytes. So in this disorder, we know, and if you go through our video on melanogenesis, we know that the melanocytes form melanin and they transfer it to a keratinocyte. Clear? So melanin is stored in melanocyte, and using the dendrites they are transferred to the keratinocyte, but this transfer is defective in cold disease, and that is why you see clumping or accumulation of melanin granules inside melanocytes. Clear? And nearly no melanocyte in the keratinocytes. So you don't have color in the melanocytes. Sorry, you don't have color in the keratinocytes, but the melanocytes have a lot of keratin granules inside them in cold disease. The mutation lies in ENPP1, ENPP1 gene mutation, and it is required for extracellular inorganic phosphate, which is an inhibitor of mineralization. So when this phosphate is not formed, you have increased mineralization and there's increased extra cellular calcium, and that is why you have ectopic calcification in this disorder. So C for cold, C for calcification. Insulin signal is also affected. If it's an autosomal dominant disorder, okay, autosomal dominant disorder, but some mutations can be transmitted in a recessive fashion, and when you have recessive transmission, you have dyschromatosis. That means light and dark areas can both be seen along with a severe form of cold disease. So remember, whenever there's recessive transmission, the severity increases. It starts in first year of life, congenital. Remember, cold disease in congenital. So three words: cornification, congenital, calcification. Sharply demarcated irregular macules with varying degrees of hyperpigmentation over the extremities. There's early onset calcific tendinopathy. In fact, calcinosis cutis can also occur. DDs include epidermolysis bullosa with mottled pigmentation, Naegeli-Franceschetti Dedoson syndrome. Let's move forward. So here we can see this kind of ill-defined, hypopigmented areas over the extremities, along with keratoderma, localized keratoderma over the palms. You can go in on Rook's 10th edition to see this picture clearly. Now, this table I've taken from Fitzpatrick page 820, and it attempts to have a approach, a diagnostic algorithm for Palmoplantar Keratoderma. So if it's mainly PPK, you will ask if there is any epidermolytic changes. If epidermolytic changes are there, then it is a form of epidermolytic ichthyosis, in which you have creatin 1 or 9 mutation. Okay. If it's not PPK, then we will not discuss it here because we're discussing PPK. If there are no epidermolytic changes, you find out other pathological features. If there's pathological features means on biopsy. If there's this addition, you have this Strate type of PPK. Okay. If you have binucleate keratinocytes, you have ichthyosis hystrix of Kurth-Macklin. Okay. If stratum corneum has nuclei or parakeratosis, you have Loricrin PPK. Okay. If there are no extracutaneous features, you see if these are punctate. If the soles are involved, you have PPK type 1. If the thenar eminences, that means at the base of the thumb is involved, you have acrokeratoelastoides or focal lateral hyperkeratosis, which is PPK type 2. Okay. If the features are mutilating, so you have Mal-De-Meleda syndrome. If it is focal or diffuse and pain is present, you have Pachyonychia Congenita. If the lesions are linear, you have click syndrome. Okay. Or you can also have that Strate PPK. If you have water sensitivity, then either you have Bolognia syndrome, aquaporin 5 mutation, which is autosomal dominant, or serpin B mutation in autosomal recessive. This is Nagashima syndrome. Okay. And another is transient aquagenic keratoderma. But remember, transient aquagenic is a feature of punctate. Okay. Let's move forward. So, again, I'm putting this slide out as a summary of the disorders along with their inheritance. Remember, two are autosomal recessive. You have Mal-De-Meleda. Sorry, let me change the color. You have Mal-De-Meleda and you have Nagashima as autosomal recessive. Others all are autosomal dominant. These are the individual genes which are mutated along with the full form of the genes, and extracutaneous involvement is seen in Pachyonychia congenita. You have the mucosa involvement, and you have cold disease in which you have calcification. So I'll wait for 5 seconds till you take a screenshot of this. It's a good summary. People have asked me that in cases of genetic disorders, I should also give a summary of genes and their the inheritance. So you can click. The disorders that are in red are the diffuse PPK. So I'll just write here. You have here the red one is diffuse PPK. The yellow one is focal PPK, while the blue one is punctate PPK. So it's the same color scheme that I've followed in the initial part of the lecture. Okay. So with that, we'll finish. These are the chapters that I've used in making this video lecture. But if you have gone through this video, you need not read this chapter. Okay. So these chapters. Again, I will request you all to consider becoming a member. It's on a reduced price till the end of this year, till 31st December, and a lot of different things keep on getting added. In fact, a good portion of this video is there only for members. The general public will have a truncated version of the videos because they cannot use some slides for you because of YouTube guidelines. So I would appreciate if you think that the content is good enough, is knowledgeable, is helping you in some way, do consider becoming a member of the channel. Okay. So with that, we'll finish the non-syndromic PPKs. I hope the topic is dry. It's difficult to understand, but I hope I've tried my level best to make it interesting. And any suggestions or doubts are welcome. You can comment them in the comment section. Any queries, you can email me, but it's better to comment. I will not take much time, even I am tired. And with that, adios and bye bye. See you next week.